Welcome to the deep dive. Today, we're not just scratching the surface, we are going right to the source, to a foundational text in neuropharmacology, the 1984 Symposium Proceedings, Dopamine Receptor Agonists.
And if you're a specialized learner, maybe a medical student or a pharmacist, this deep dive is really for you. It's your blueprint.
Right, because dopamine is so much more than just the pleasure molecule. It's movement, hormones, even blood pressure.
Sure.
So let's unpack how the pioneers first mapped this whole system.
That's our mission today, to give you that essential map. In the early 80s, researchers were really struggling. Drugs did different things in different tissues.
Total chaos.
Pretty much. So this book, it lays out that first crucial classification. The two major receptor subtypes, D1 and D2. We're going to define them, look at their mechanics, and then trace their impact.
All the way to the clinic. We're talking shock, heart failure, and even neurological disorders like Parkinson's. So we have a clear plan. First, the classification itself. Then we get into the nitty-gritty molecular details. And finally, the clinical applications, connecting the science right to the patient.
Okay, so to even appreciate this D1, D2 distinction, you have to remember that classifying receptors is always a work in progress. It's driven by discovering new, more selective drugs.
It's just like what happened with adrenoceptors, right?
Exactly the same story. Before the late 70s, nobody could agree on how many dopamine receptors there even were. Different drugs, different actions. It was a mess.
And that mess led to the big breakthrough, the 1979 hypothesis from Kababian and Kalani.
Precisely. They proposed two categories to try and bring some order to the chaos. Let's start with D1.
Okay, D1, what's its defining feature?
It's all about its biochemical action. The defining feature of a D1 receptor is the stimulation of an enzyme called adenylate cyclase.
Which in turn leads to more of the second messenger, cyclic AMP or CAN-MP.
Exactly. It turns the system on.
And where do they find the best, sort of cleanest model to study this? You'd need a tissue where the effect is really clear.
But the prototype tissue they used was from the bovine parathyroid gland. And what was so perfect about it was that the increase in CAMP from dopamine was directly, causally linked to more parathyroid hormone release.
So it wasn't just a correlation. It was cause and effect.
A clear mechanism. Interestingly, dopamine is actually less potent here than at the D2 receptor. Even apomorphine is just a weak partial agonist.
This is where it gets really useful for researchers, right? The tool compounds.
Yeah.
What was the key drug that let them finally isolate D1's role?
That would be SCH-23390. This compound was a massive, massive game changer.
Why? What made it so special?
It's an incredibly selective D1 antagonist. I mean, it has a binding affinity, a Ki of just 0.66 nanomolar. It's super tight. Before this drug, you couldn't really tease out what D1 was doing in the brain or the heart because all the other drugs were too messy. They hit other receptors.
So SCH-23390 basically made D1 research possible.
It made it legitimate, yeah.
Okay, so now let's flip the switch. D2. If D1 is the accelerator.
Then D2 is the brake. It's defined by inhibition.
Inhibition of what?
Either inhibiting the release of neurotransmitters from the nerve terminal or directly inhibiting that same enzyme, adenylate cyclase, inside the cell.
And what was the prototype tissue for D2?
For that, they often used the melanotrophs from the rat pituitary's intermediate lobe, the IL. The great thing about that prep is that it's a very pure, homogeneous population of cells.
Which makes isolating the mechanism much easier.
Much, much easier. And the drug profile just confirms the difference. Dopamine is way more potent on D2.
And you see those ergot derivatives, like lisuride.
Right. The ergots are potent, full agonists at D2, but then, bizarrely, they act as antagonists at D1.
Strange. And for selective D, two antagonists.
The classics are sulpiride and metoclopramide, but to really see how specific they could get, you have to look at another tool compound.
Which one was that?
A drug called YM091512. Extremely potent. As a D2 blocker, it's right up there with a major neuroleptic like flufenazine.
But the key is its selectivity.
The key is that it is 1,000-fold less potent as a D1 antagonist. That kind of selectivity, that's the only reason we have this two-receptor model today.
1,000-fold. Wow. Okay, let's get down to the molecular level. How do they actually work? We know D1 activates adenylate cyclase. What does it need to do that?
It's absolutely dependent on GTP guanosine triphosphate.
Which immediately tells you there's a G protein involved.
It screams G protein. Now, for D2 and its inhibitory effect, this is where the mechanics get really different.
How so? In that pituitary model, what's happening?
It's the core distinction. D2 activation decreases the cell's ability to make CAM and T. It couples to adenylate cyclase not through a stimulatory G protein, which we call NS.
But through an inhibitory one.
Exactly, through an inhibitory guanyl nucleotide component, or NS is the accelerator, and Ni is the brake pedal.
And how do they actually prove that Ni was the go-between?
Well, they use these clever non-hydrolyzable versions of GTP. So the inhibitory effect of one of these analogs on the cyclase enzyme could be reversed by adding normal GTP.
Okay.
But, and this is the key, if you have a D2 agonist like apomorphine present, it prevents that reversal. It holds the breakdown.
So the agonist is controlling how that G protein interacts with the enzyme.
Precisely. It confirmed the Ni link, fitting right into Rodbell's model for other G protein coupled receptors.
Fascinating. And this complexity, it even changes how the drugs physically bind to the receptor.
It does, especially for D2 agonists. When you use a radio-labeled antagonist like spiroperidol, you get these nice, clean binding curves.
Simple and predictable.
Right. But when you look at agonists, things get weird. The dose-response curves are often really shallow.
What does a shallow curve actually tell you?
It's a huge clue. It suggests the receptor can exist in at least two different states, a high-affinity state and a low-affinity state.
And that high-affinity state is the one that's doing the work.
That's the one. It reflects the formation of a ternary complex. That's the agonist, the receptor, and the G protein all bound together. That's the functional on state.
So if you're screening new drugs, this is a major complication. A drug could bind to the receptor alone, but do nothing if it can't form that three-part complex.
It complicates it immensely. You have to make sure your assay can detect the formation of that complex. Otherwise, you're just measuring binding, not function.
And this issue even popped up with some of the established ergot drugs.
Oh, yes. Some of them, even though they were powerful agonists, had binding properties that made them look like they were binding irreversibly, like an antagonist.
So they looked like they were just plugging up the receptor permanently.
Right. But further studies, using a radio-labeled ergot, showed the binding was completely reversible. The weirdness wasn't the drug sticking like glue. It was all about dynamic changes in the receptor itself, like the cell pulling receptors off the surface after they've been stimulated.
Okay, let's move out of the central nervous system and into the periphery. The blood vessels. Here we talk about DA1 and DA2 receptors.
Right. It's a slightly different terminology, but it maps functionally onto D1 and D2. DA1 is the postsynaptic or postjunctional receptor.
And its job is?
Vasodilation. Simple as that. Stimulating it makes vascular smooth muscle relax.
And where is that most important in the body?
Oh, it's critical in the renal arteries, the mesenteric ones supplying the gut, cerebral, and coronary arteries. It's all about maintaining blood flow.
And what's the go-to selective drug for studying DA1?
That would be SKNF 82526. It's potent, selective, and crucially, it doesn't have any of that messy alpha adrenoceptor activity that confuses the picture with other drugs.
Okay, so that's DA1. What about DA2 in the periphery?
DA2 is prejunctional. It's found on the nerve endings of the sympathetic nervous system, on the noradrenergic axons.
So it's not on the muscle itself?
No, it's on the nerve that controls the muscle. And when you activate a DA2 receptor, it puts the brakes on norepinephrine release.
I see. So the end result is?
You get less norepinephrine, so you get a lower heart rate and a passive vasodilation. It's a really important negative feedback loop, especially when your sympathetic system is in overdrive, like in a state of shock.
Now, you mentioned a debate. For a long time, dopamine was just seen as a precursor, the stuff you make norepinephrine out of. Does this source support the idea of a dedicated, separate dopamine system in the periphery?
It strongly supports it. I mean, they found that dopamine is the main catecholamine in these specific cells in sympathetic ganglia called CES cells. And some of these function as actual interneurons.
So they're not just warehouses for a precursor. They're using dopamine as a transmitter.
Exactly. And they even visualize dopaminergic nerve elements right in the kidney at the glomerular vascular poles. This points to a specific local regulatory system. It's not just an any starter kit.
And that has huge implications for treating things like hypertension.
Massive. If you can target these peripheral DA2 receptors with an agonist like pergolide, you can directly reduce sympathetic outflow. That lowers blood pressure and heart rate. It pointed to a whole new way of thinking about antihypertensive therapy.
Let's bring this right to the bedside. The classic example is a dopamine infusion for a patient in shock or congestive heart failure. The dose really matters here.
It's a perfect illustration of how this all works. At a very low dose, say zero point 0.5 to 2 micrograms per kilogram per minute, you're mostly hitting DA1 and DA2.
So the DA1 gives you that vital renal vasodilation helping the kidneys.
Correct. You get better urine flow. And the DA2 activation starts to inhibit norepinephrine release.
Then you turn up the infusion.
You go up to a moderate dose, maybe 2 to 4 mics. Now you're starting to activate beta-1 receptors in the heart. That gives you increased contractility, increased cardiac output, great for blood pressure.
But wouldn't that normally cause a dangerous reflex tachycardia? A racing heart?
It would. And this is where dopamine is so elegant. The simultaneous DA2 activation is still happening, and it's putting the brakes on that norepinephrine release. It helps blunt that reflex tachycardia. It provides stability.
It's like having a built-in safety mechanism.
It is. But if you push the dose too high, you start hitting alpha-adrenergic receptors, and you get widespread vasoconstriction, which can be detrimental.
I see. And for more chronic conditions like heart failure, they could use more selective DA2 agonists.
Exactly. Drugs like bromocriptine or an oral prodrug called ibopamine could improve cardiac output and reduce resistance, all without that unwanted acceleration of the heart.
Okay, let's shift gears to neurology. In Parkinsonism, the problem is not enough dopamine activity in the striatum.
Right. And this is where direct-acting agonists have a huge advantage over just giving L-DOPA. They bypass the failing enzyme LDOPA decarboxylase that's supposed to make dopamine.
You're talking about D2 agonists like bromocriptine and percolide?
Yes. And percolide was particularly interesting. It's much more potent than bromocriptine, and some studies showed it was better at reducing those awful on-off fluctuations and psychosis that some patients experience.
Now, for the flip side of that coin, what happens when you block dopamine receptors for too long? I'm talking about tardive dyskinesia, or TD.
TD is just this terrible potential side effect of long-term neuroleptic use. You're blocking dopamine receptors for months or years, and the brain tries to compensate.
It upregulates the receptors, making them hypersensitive.
The system becomes hyper-responsive. So if any dopamine gets through, or if you stop the drug, you get these uncontrolled movements.
What did the early animal models tell us about the risk factors? This seems critical for doctors to know.
The animal work was incredibly clear. They found that the risk for developing this behavioral hypersensitivity depended on two things. The duration of the therapy, sure, but also the daily dose. It's the combination of how much and for how long.
Concentration and time. That makes sense. Finally, let's touch on the endocrine system. There was a surprising finding there about aldosterone.
Yes, this was really interesting. It appears that aldosterone secretion, the hormone that controls salt and water balance, is under maximum tonic dopaminergic inhibition.
How do they show that?
They gave a D2 antagonist, metoclopramide, and aldosterone levels just shot through the roof.
So blocking dopamine released the brake. But wait, if it's under maximum inhibition already, then giving a D2 agonist like bromocriptine shouldn't do anything to the basal levels.
And it didn't, which is exactly what confirmed the theory. The system was already fully inhibited by the body's own dopamine. But it also raised a new question, suggesting the receptor-controlling aldosterone might not be exclusively the D2 subtype we know. There are more complexities.
So this whole deep dive really lays out the foundational map. You have at least two distinct opposing systems, D1 for stimulation, D2 for inhibition.
And you see how developing those ultra-selective tools like SCH-23390 was the key to unlocking their therapeutic potential everywhere from hypertension to Parkinson's.
It really is the key, moving beyond just a drug's name to its specific receptor action.
That is the ultimate goal for any specialized learner. So to make sure you've really integrated this, I'll leave you with a quick clinical scenario to think about.
Okay, let's hear it.
Imagine your patient is in cardiogenic shock. You start a dopamine infusion at a moderate rate, say 3 micrograms per kilogram per minute. Now, we know the beta-1 effect is going to increase cardiac output. My question is, based on these foundational classifications, how does the simultaneous activation of the D2 receptor specifically help maintain cardiovascular stability, and why is that so critical in contrast to just the beta-1 effect alone?
That's a great question. It forces you to connect the peripheral projunctional DA2 action with the clinical dose response. Think about what the heart would naturally want to do when you crank up its output and what DA2 prevents. That's the kind of thinking this foundational science empowers you to do.
Exactly.
Until next time, keep digging into the details.